Agus. Tá buíocha bhfuil seansa go an tábhair seo a phléin inniu, and I'm very grateful that this topic was chosen, and I know it was chosen before the recess, but I waited so that the Minister would be here to address this. I'm sure you, like me, have had family and friends who've suffered strokes. So we know we're not just seeing it from the medical point of view, but also from the emotional and the psychological effects that it does have on the person and on those who love them. And we know that there are personal costs, there are emotional costs, and there are psychological costs along with the physical ones. Because we know that stroke is a life-changing experience. Now, the financial cost, and I'm told it's over 550 million a year, with over 400 million of that going on nursing home care. 75% of stroke victims never go back to work, and that there are major difficulties for stroke victims and their families. Now, I want to acknowledge first, when the HSE launched the National Stroke Programme 4 years ago, the death rate from strokes in Ireland fell by 13%. The rate of discharge of patients from hospitals to nursing home care was down 28%. So the savings from that reduced requirement for nursing home care conservatively estimated at about 22 million, and all of that was very positive. And those positive results came about, I think, because the HSE invested in this. They invested in the stroke network because they listened to people and they took account of the reports that were done. That better acute stroke services would save lives and money on a significant scale, and that was what happened. So I'm coming to the crux of my topical issue, which is the need for the community rehabilitation services, because better community rehabilitation services can maximise recovery. And I want to acknowledge the work of the Irish Foundation here and the research that they had introduced. 44% of all stroke sufferers, more than 3,000 people per year, are in the mild to moderate stroke category, and they could benefit from early supported discharge programmes. So the idea is get them home earlier. And I think government health policy in a lot of areas is about getting people back to their families and back to their communities. And I know we're very much in favour of that with mental health issues. So that's particularly valuable, I think, in this area. I think those figures that I mentioned on stroke, we could see how much could be saved by letting people back out into their communities. It's estimated perhaps 12 million from reduced hospital length of stay would be saved. And it would also free up the number of hospital beds annually, which we know are in demand. So it's expected that an initial outlay of between 5 to 10 million is the cost annually to resource community therapy and community services. So the cost to implement is considerably less than the cost of inpatient stay. At the moment, we know so much is going into nursing home care. Those in the mild to moderate range are losing out when they leave hospital because they need physiotherapy, occupational therapy, speech and language therapy. And I think it is better for them to be at home when they would have services and a greater delivery of care in the community. There was one quote I just want to include here, which is from the ESRI and Royal College of Surgeons report for the Irish Heart Foundation. Clinicians in 24 out of 28 acute hospitals agreed that inadequacies in community services lead to referrals of patients for rehab in smaller hospitals, other inpatient locations or nursing homes who could be treated at home by community services if these were available. Nursing home costs would be reduced if more stroke patients are able to live independently at home. And I am hoping that there will be a positive response to a small outlay of funding to bring this about, even on a pilot scheme, to show that it will work.
Thanks, Deputy. And the Minister has 4 minutes to respond.
Could I just start by saying that, Deputy O'Sullivan, a lot of what I'm going to read in the first 2 pages you've already done so, but I'm going to do it anyway, because we do need to lay out the context in which we're having it. Now, I am glad to be here myself in order to take this, because it's an area, just like yourself, that I have a particular interest in because of family circumstances. I would like to thank Deputy O'Sullivan for raising this issue today, and I am pleased to take this opportunity to outline the position in relation to this matter. Since 2010, the National Cardiovascular Health Policy has seen significant improvements have been made with regard to access to acute treatments for coronary heart disease, as well as the development of stroke units across the country. Key elements of stroke care now available include new and existing stroke unit provided with additional therapies, nursing and consultant post. Thrombolysis is now available to acute hospitals admitting stroke patients, and the Deputy will have a lot of these figures herself. 9.5% of whom are being thrombolised, which compares well with the best European figures. The aims of the National Stroke Programme are to provide national rapid access to best quality stroke services, including acute care and the implementation of early support discharge services. The implementation of ESDs, which is the early support discharge services, is within the context of the wider range of rehabilitation services required by stroke patients. The stroke programme estimates that the number of people with enduring disabilities, and I think this is where the key advances have been made as a result of stroke, has decreased as the percentage of patients with stroke discharged from acute hospitals to nursing homes has dropped from 17.3% in 2009 to 14.5% in 2012, and it's gone down again since then. The percentage of patients discharged directly home has increased from 49.4% in 2009 to 51.1% in 2012. A certain percentage of stroke patients will be suitable for early supported discharge, which includes intensive specialised stroke rehabilitation provided in the patient's home for up to 8 weeks. This reduces the length of hospital stay, and again, just like the Deputy, I would agree entirely. The notion that, that you should be somehow confined to a hospital bed, when you could have the treatment you need in the comfort of your own home to a certain degree, it just makes no sense to me. This reduces the length of hospital stay, reduces long-term dependency and the risk of further disability after 6 months, as well as reducing the number of patients requiring long-term care. ESD service are currently funded in a number of locations. The feasibility of implementing this model in geographically dispersed populations is limited. The NCPS continues to provide funding to these sites. During 2013, a total of 90 patients were discharged home via the ESD services across 3 ESD service sites: the Mater University Hospital, Galway University Hospital and Tala Hospital. Patients requiring more intensive rehabilitation are referred to the nearest available rehabilitation service. The establishment of managed clinical rehabilitation networks of neurological and physiological physiotherapy rehabilitation service in each of the 4 HSE regions contributes to rehabilitation services. The National Rehabilitation Hospital provides specialist stroke rehabilitation as a national hub and links in with regional services. The Department of Health's national policy and strategy for the provision of neuro-rehabilitation services in Ireland, in collaboration with the National Clinical Programme for Rehabilitation Medicine, provides for improved access to and quality of services for patients requiring rehabilitation. The Rehabilitation Medical Clinical Programme and the HSE Disability Service Division are developing an implementation plan for the neuro-rehabilitation strategy. Primary care also plays an important role in stroke rehabilitation. As of the 6th of September 2014, 229.5 of the 264.5 primary care team posts have been filled, or start dates agreed, and I think this is a key, and the Deputy recognises that to what we need to do in the community. The HSE is striving to have the remainder of the posts filled as soon as possible in 2014. Taken together, all these developments shows that we have made significant progress in preventing stroke and its complications. The issue of how best to further develop and support early stroke discharge is under consideration by the HSE stroke programme. But as the Deputy will know, and a recent experience of this, and not in my own family but a friend, that it very much depends on how quickly you get to the unit that has the capacity to deliver the relevant treatment. And unfortunately, in one case recently, that didn't happen.
Thanks.
Thank you very much. Thank you for the reply, Minister. I think we're saying the same thing. It's opportune because World Stroke Day was the 29th of October last. And I think the point is that all the reports and the findings and the opinions of people who work with stroke victims all say the same thing. Proper consultation, proper organisation and better community therapy services for stroke survivors will improve their quality of life on a major scale. And we would see more cost saving than the current system. system. So there's an economic justification for the rapid development of community rehab and care services. And we're also talking about international best practice. But above all, I think there's a greater justification on the personal side, because it's about making a difference in the lives of those who suffer stroke and those who love them. And my own recent experience of a person who had a stroke, hospital quickly, hospital care was excellent, and then to the nursing home. But I think spent far too long in the nursing home. And in the nursing home, while the care was there and the therapy, it was too intermittent and it was too short. Whereas if that person had been at home, getting the community care with the family and the community and the friends around him, encouraging him, I think more therapy, you know, the informal type of therapy, I think would have been much more valuable. So I do think that there is an urgency about this if we are going to make a difference. I don't think the services are looking for a blank cheque. It's not an astronomical amount of money, but it is an amount of money that can make a big difference.
I'll be very brief. Deputy, I couldn't agree with you more. And I think the joining up of the post that we're putting into the community and, you know, that sort of interconnection between primary care teams, you know, community intervention teams, all of that. And the other thing I saw, which I was very interested in, and I know first-hand experience, that when it is treated quickly and in the correct location, that the outcome can in fact be as if the stroke never occurred. It is quite incredible, and I would credit both the last government and ourselves in terms of that, identifying it and how it works. But the other thing I saw recently, which I was hugely impressed by, was a normal, straightforward gym, but had equipment that everyone could use in terms of balance when it comes to stroke, in terms of muscle capacity and all of that. And yet in the same gym, as I was going to say as you and I would use, but you know, as the general population would use. You know, it was just, and it wasn't a matter of different equipment, it was simply equipment that could be used by both the able-bodied and people who needed that additional little piece of help. So I think we're on the right track, but we need to do more.